Thank you very much for, I would say, taking your time in the late afternoon. Okay, so I'd like to talk about the cultural cells for Bullous keratopathy, but more conceptual aspect. So there are financial disclosure to make, and the company's name highlighted in block letters are relevant to this presentation. Well, we've been proposing the CHCC, this cultured corneal endothelial cell transplantation therapy, started from a very young donor allogenic cells. And then we could make the cultured cells for 1,000 patient starting from just one pair of the donor cornea. But I think a regulatory authority allowed us to make just for the 300 at this point. Well, this is just example of the corneal endothelial failure preoperative and also the postoperative. So and we published the 2-year data in 2018 for the initial 11 cases, and also in 2021 for the 5 years data of this is the initial 11 cases. Most of them, one case of the PEX syndrome related to Bullous keratopathy was failed at the 3 years postoperative, but the 10 cases still they are transparent for the almost 10 years. Well, and then once again, I would like to explain to you, taking the young donor corneal endothelial cells, and then cultured to some certain time. Generally speaking, it's about 3 months, 4 months, something like that. And then eventually making the cells suspension, and then after the cell suspension making, and we inject the cells within 27 hours at this point. But at that time, we injected within 6 hours or so. And this is the first case and the second case. First case is laser-induced Bullous keratopathy. The lower portion is a Fuchs endothelial corneal dystrophy. And up to 9 years postoperative, you could see the cornea is transparent, and also visual acuity is like a 20/20 vision. Corneal thickness come down to less than 600 micron. So this is more like what about the reverse translational scientific aspects of this kind of procedure? We think this could tell us at least 3 major things. One is we could make the mass production of the cultured corneal endothelial cell, the use of the culture. And also started from the very young donor cornea. So that means we could perform some kind of rejuvenation of the posterior corneal surface. And number 3, for us, this is the most important, self-organization. We only just inject these cultured cells into the anterior chamber, not the tissues, only the cells, although we use a low kinase inhibitor supplementation. But they are sedimented on the descemet membrane, and then they make the posterior surface of the corneal endothelial cell layer. So conceptually, I love self-organization of these cells. So the culture of the human corneal endothelial cells and the use in a clinical setting, that was proposed by the Nancy Joyce in the year 2000. And she was already retired, but she proposed that could be possible for the next 5-10 years or so. But at that time, she tried to make the culture cells from the in vivo corneal endothelial cells. But they could culture, but there are a variety of the cultured endothelial cells, including the CST or EMT cells as well. But we really want to make the cultured cells that is mimic to the in vivo corneal endothelial cells. So, for instance, at when I gathered the several the published papers, they shows the pictures. According to these pictures, most of them are either getting into the CST or EMT. Very few are the healthy corneal endothelial cell characters. Well, thanks to the low kinase inhibitor, that was suggested by the Professor Yoshiki Sasai. He's a very basic the scientist, and then he said to us, why not using the low kinase inhibitor for the initial attachment of the corneal endothelial cell culture. And then, so therefore, we use the Y27632, and you could use the other type of the low kinase inhibitor as well, but still the Y27632 is the best for us for the cell culture of the corneal endothelial cells. And then, please take a look at that, this mass production. This one is the passage to, and takes about 3 months or so, and we could make the culture cells for about 70 patients. But when we could expand to the passage 5, although we need more time, but we can create the culture cells for at least over the 3,000 patients. And also the endothelial cell morphology is more like in vivo corneal endothelial cells. And then we modified our culture system, and then more shorter time, like 3 months or so, within 3 months, we could make the culture cells for over the 3,000 the patients. So that's a reality. But however, this is a more like academic science. The regulatory science is different from the academic science, and we really have to prove, or that we have to go the proper process to persuade and get an acceptance from the regulatory authorities. So at this point, we could only make up to the 300 culture cells for the 300 patients. So once again, as I said, that we could make the culture cells, but we are aiming at the culture cells for highlighted in blue. And how can we know that? That is based upon the FACS analysis. For instance, CD44 negative, 105 negative, 2426 negative, and something like that. So this is a more like a quality control standard, and not highlighted in red. That is in danger when we inject into the anterior chamber. Now, what's the difference between them? Cells itself, when we are thinking analyzing the energy metabolism pathway in mature cell and also cell state transition cell highlighted in red, they are different, different. And highlighted in blue, these cells tend to use a TCA cycle, but not the red. CST or EMT cells, they are more going to the glycolysis pathway. So the mitochondrial function is still in normal or healthy in highlighted in blue, but not in red. So that's a key issues of that. So and then we compare the clinical results. Group 1 is a mature cell is about 70%, but there are some kind of contaminated cells as well, CST cells about 20-30%. The other one, group 2, is over the 90% pure, I would say, the mature differentiated cells. And compare these two based upon just the morphology under the inverted microscope. We couldn't tell the difference, but the FACS analysis shows that some of the difference in the group 1 and group 2, and compare their clinical results at 3 years post-operative. We published this paper in AJO about a couple of years ago. So group 2, when we inject the same amount, group 1 and group 2, we inject the same amount, 1 times 10 to the 6 into the anterior chamber. And then there are a variety of the Bullous keratopathy, but there is not much of the difference in a clinical situation. And group 2, at the 3 years post-operative, average is over the 3,000 cells per square millimeter. I didn't see such kind of high corneal endothelial cell density after the PKP, DSEC, or the DMEC procedures, as compared to the group 1. Group 1 is an ordinal DSEC or the PK, something like that. So not only for that, the morphology itself is also the different. That it's more like a endothelial cell appearance after the cataract surgery. So they are self-organized. sedimented on a desmoid membrane, and then make the cell-cell contact, and then eventually they had a very stable posterior surface of the corneal endothelial cell layer. So this is a total Bullous keratopathy patient, and we inject the cells. So these cells you're seeing are supposedly coming from the injected cells, 4 months postoperative. So, and also this procedure can be applicable in graft failure after the PKP or the DSEC procedure. That we haven't done anything about the failed DMEC procedure. And also, ELISpot assay in a human clinical trial showed no antigen recognition occurred by the host. So we think it's safe enough. It's almost safe enough in terms of the allogenic reaction, endothelial rejection, even for the failed PKP due to the immunological reaction. So, and then about 2 years ago, Japanese government approved the product name is Biznova as a registered medicine product, and last September, the government sanctioned, government-supported health insurance system coverage for this product in Japan, along with a newly established surgical fee for the transplantation of these cultured endothelial cells. So we are thinking of the global kind of standard medicine. So started from Japanese phase 2 and phase 3 clinical trials. And then during that time, we shipped over the cultured cells to the El Salvador. And then US doctors come down to the El Salvador and then perform these cell transplantation surgery. Total is 90 cases. And this is a more like a repetition study. And then they understand this is working, so therefore the Orion Biotechnology made the lab in Boston, and then they performed the phase 2 and the phase 3 clinical trial in the US and Canada. And phase 2 clinical trial was already finished, and I've heard they had successful results. So what future discoveries rise on the horizon? One is mass production and the donor selection of the cultured CCs, and then try to increase the number of the cultured cells for the more patient. And also storage and transportation for cultured endothelial cells. For instance, freezing with a DMSO or other freezing procedures, and also long-term maintenance of the CC suspension, something like this. And we really have to work on that. And also improved surgical procedures such as bimanual technique or triple procedure or CC transplantation with a DSO for the Fuchs endothelial corneal dystrophy. So this is a kind of a group work of the KPUM, thanks to the Professor Chie Sotozono and her group, and also my colleagues. So thank you very much for